Hello, friends, once again. Today we're going to talk about diagnostic approaches to urinary tract infections. Remember, we already did introduction and risk factors to urinary tract infections, and later on our second version of this series, we also did the pathophysiology and the complications plus the clinical manifestations that come with urinary tract infections. Today, we are going to talk about diagnostic approaches and treatment for urinary tract infections, that is both um, uncomplicated urinary tract infections and complicated urinary tract infections, and also looking at the bits, that is the upper urinary tract infections, that is pyelonephritis, and the lower urinary tract infections, that is the cystitis. Now, before we get there, friends, if these videos help you, if they help you learn, if they make you join the bigger team, the growing team of Medscope with Benson, please help us by subscribing, sharing these videos, and liking, hitting your like buttons, friends. We can't insist that enough. So that said, let's dive right deep into the approach to urinary tract infections. So pretty good. What we're going to do is first recall ourselves to what were some of the symptoms of urinary tract infections. So, one, for urinary tract infections, we need to know what type of urinary tract infection are we talking about. So, number one is cystitis. This is for your lower urinary tract infections, and at this point in time, you have the symptoms. Remember, guys, from when we were doing our play on both the upper and lower urinary tract infections. We said for cystitis, suprapubic pain, okay, dysuria, okay, that is burning urination, urgency, frequency. You remember when we were saying, they want to go oftenly, and if they want to go, they want to go now, and if they want to go now, they can barely get that urine out. That is for the urgency. For pyelonephritis, friends, we're talking about the flank pains plus the costovertebral angle tenderness. We're talking about the systemic inflammation symptoms. That is the fevers, the chills, plus, your elevated WBCs, that is the leukocytosis. So what you want to insist here mostly is when you want to get your urine sample, okay, because one thing really want to start with, it doesn't hurt, friends, is doing your urinalysis. So obtain your urinalysis. And this is point in time, please ensure that you get your midstream catch. We just want to ensure that the urine you're getting is right from your urinary bladder, so that it doesn't just come from your urethra for the first catch that is. Now, while you're doing all this, we just want to ensure that the squamous cells are less than 5 cells of HPF to rule out contamination. Sometimes when you have this cut, you're likely to get them contaminated. So it's an important clinical note to ensure that the squamous cells are less than 5 HPF to rule out contamination. So let's dive right into urinalysis. Just do a urinalysis, okay? It doesn't hurt, friends. So you got your urinalysis. So what you're going to realize is for cystitis here, the positive findings from your urinalysis will be the leukocyte esterase. Okay, remember this is when your polymorphonuclear neutrophils are busting open. So and that you're also going to get your pyuria. This is your white blood cells in urine. Plus, if you're talking about the gram-negative rods, bacteria, okay, they have the enzyme that is able to convert your nitrates to nitrates. So that is going to confirm your cystitis, okay? Right? So, and then later on, also, you're going to get, for pyelonephritis, same urinary symptoms. That is leukocyte esterase, the enzyme that you already talked about, the white blood cells in your urine, that is pyuria, plus your nitrates, if you have the gram-negative bacteria, and this is somehow, I can't insist this enough. The WBCs casts. You remember that? You're saying if these WBCs get into the tubules and take the shape of that particular tubule, that is basically very pathognomonic for the pyelonephritis. So having done that, we will either classify these cystitis to whether it is complicated or uncomplicated. So for complicated cystitis and for the uncomplicated, cystitis patients, we're going to check on now they have the uncomplicated cystitis. Now the treatment here, we basically want to employ nitrofurantoin, sulfamethoxazole, topium sulfamethoxazole, that is simply Septrin, and fosfomycin. I'll tell you, my friends, we have always used nitrofurantoin. Rarely have I seen fosfomycin in clinical practice, but then it's part of the clinical guideline. For complicated patients, so obtain that urine culture, okay? So this complicated cystitis plus our pyelonephritis, all patients, I can't insist that enough, all patients for pyelonephritis, just ensure you get your urine culture, and if they have bacteriuria positive and with cystitis symptoms, please just know that that is complicated cystitis, and the treatment here is we use the fluoroquinolones, that is ciprofloxacin or levofloxacin, and sometimes trimetoprium sulfamethoxazole, that is your Septrin. So another aspect for now our pyelonephritis. Remember, I have insisted that our pyelonephritis patients, please obtain your urine cultures. So positive for bacteriuria in your urine, it confirms with pyelonephritis symptoms, then we want to consider for these pyelonephritis patients, are we going to approach them as inpatients or outpatients? If that happens, then we need to know for the outpatients, for the inpatients, that is, these patients are hemodynamically unstable. So for inpatient pyelonephritis, your ceftriaxone will never lie, okay? So IV ceftriaxone is your first line. But then sometimes when it's not able to work out for you, you can go for piperacillin, tazobactam, or cefepime, plus what is known as IV meropenem or ertapenem, okay? Now, for hemodynamically stable patients, that they're tolerating orals, they can take the oral medications, they're able to take fluids with them, just ensure that we are doing ciprofloxacin, levofloxacin, plus I can give them one intravenous injection, one intramuscular injections for IV ceftriaxone, okay? Now, sometimes if these patients are unstable and you have an inpatient pyelonephritis, okay, you've given your 48-hour period to 72 first-line ceftriaxone, or probably you considered giving piperacillin, tazobactam, or cefepime, plus probably IV meropenem and ertapenem, and these patients lack improvement, okay, between those that given period of treatment, 48 to 72 hours, and they're hemodynamically unstable, you must start thinking about the complications of this particular pyelonephritis. So think. Let's do a CT abdomen pelvis plus your renal ultrasound. If you're good at it, then you're able to pick your perinephric abscess, okay? You're either going to pick a perinephric abscess, or probably there is some other issues, the complications that we already talked about in that regard. So for our perinephric abscess, if it's less than 3 centimeters, you got to do your IV antibiotics, plus if they're equal or greater than 2 centimeters, please, you need to drain. So you can do your antibiotics plus your percutaneous drainage, okay? Now, if these same patients have had, from your CT, you're able to see a positive for hydronephrosis and hydroureter, consider that a stone, okay? That is urolithiasis. So the treatment would be your IV antibiotics plus a ureteric stent or a percutaneous nephrostomy. Okay, now if you did the same city, okay, and you realize that you're able to pick an air or gas in your renal parenchyma, you need to consider that as the emphasis matters. And remember, at this point in time, these patients have to be diabetic, okay? So treatment would be IV antibiotics and probably a nephrectomy. Important additional clinical information that we need to know for urinary tract infections. Number one, recurrent urinary tract infections. That means they have had more than or equal to 2 UTIs or 3 UTIs in 1 year. First thing that you have to push for, my friends, is behavior modifications. And the first one is hygiene. You can't insist enough on hygiene, okay? Probably they're not supposed to be wiping if they are females, okay? Wiping from their back to the front. And you also need to know that there is what is termed as postcoital voiding, okay? Probably after sexual intercourse, they're able to have or pee, okay? The urine out. That's first line. The second line is the pharmacologic approach. That is probably having a one-time dose of trimethoprim, sulfamethoxazole, or nitrofurantoin status post-coitus. Okay. The second aspect is for asymptomatic bacteriuria. You don't need to treat them, especially if they don't have symptoms. Okay. So, son of a gun. So 10 raised to power 6 coliformal the coliform units per mil of urine culture. You need to treat them only if they are pregnant or they are intending to have pre-urologic procedure with culture as directed antibiotics. Finally, this is a high yield tip. So if these patients, for example, had a Foley catheter, for example, in situ, and you think they have this complicated urinary tract infection, you simply need to exchange this Foley catheter, especially if you are suspecting catheter associated urinary tract infections. Having said that, friends, we have gone through the approach to urinary tract infection and the treatment therein, the first line, second line, plus if you're anticipating the complications of urinary tract infection. One thing we need to know is this brings to an end to urinary tract infection series, and until next, thank you so very much, my friends.